Did you know that the bone most commonly broken in the arm, often leading to a distinctive dinner fork appearance, is actually just an inch from your wrist?
It's surprisingly common.
It really is. It's a significant challenge orthopedic professionals face daily, yet it's far more nuanced than it might first appear, isn't it?
Absolutely. There's a lot to consider.
So today, we're taking a deep dive into distal radius fractures, those incredibly common wrist breaks that impact, well, really everyone from young athletes right through to older adults.
A very broad spectrum.
Exactly. We'll be exploring not just why they happen, but how modern practice approaches diagnosis and treatment to ensure the best possible outcomes for patients. Joining us to navigate this complex landscape is an accomplished expert in musculoskeletal trauma. Welcome. So let's unpack this. What exactly constitutes a distal radius fracture? And given its commonality, what are the sort of underlying patterns driving its prevalence?
Well, distal radius fractures, or DRFs as we often call them in the field, are essentially breaks in the radius bone, specifically very close to the wrist joint itself.
Okay.
The radius is the larger of the two bones in your forearm, positioned on the thumb side.
Right, got it.
What's truly fascinating when we look at the epidemiology of these fractures is a distinct bimodal distribution in the patient population.
Bimodal. How so?
We see a significant peak in children and adolescents. This is typically as a result of high-energy trauma, like playground falls, sports injuries, that kind of thing.
Right, the usual childhood scrapes.
Exactly. But then there's a second, equally pronounced peak in adults over 50. And what's particularly striking is its prevalence among Caucasian women over 65.
Oh, that's specific.
Yes, for this older demographic, even a low-energy fall, perhaps just a simple trip from a standing position, can lead to a fracture.
Wow.
And this is, crucially, often strongly linked to conditions like osteoporosis, which affects a substantial portion around 40% of postmenopausal women.
40% is huge.
It is. And the overall incidence of DRFs is actually on an upward trend globally. We think this is due to factors like increasing childhood obesity, perhaps leading to more falls, and certainly an aging population living longer, often with multiple comorbidities impacting bone health.
So it's complex.
It really underscores that a distal radius fracture isn't just one disease. It's almost two entirely different clinical challenges needing distinct preventative strategies. One focused on trauma prevention in the young, the other on systemic bone health in the elderly.
That dual nature is quite a revelation. And it's that very common mechanism, the fall on an outstretched hand, the foosh injury that often dictates how these fractures present, isn't it?
Precisely, yes.
Could you walk us through the different patterns we typically see from a foosh injury?
Absolutely. The foosh mechanism is, without doubt, the most common cause across all age groups. However, the precise pattern of the fracture can vary significantly. Depends on how the hand is positioned at impact and the exact force applied. For instance, a Colles fracture, first described by the Irish surgeon Abraham Colles way back in 1814, typically results in the discal fragment of the radius tilting upwards, dorsally.
Ah, the dinner fork.
That's the one. Creating that very characteristic dinner fork or silver fork deformity you mentioned, it's quite unmistakable on an X-ray.
Right.
Conversely, its opposite, the Smith's fracture, involves a volar or palm side downward tilt of the fragment, sometimes referred to as a garden spade deformity.
Garden spade. Okay. Less common, maybe?
Less common than Colles, yes, but still significant. Then we encounter more complex types, such as Barton's fractures. These are intra-articular rim fractures, meaning they go into the joint, and they can also involve joint dislocation, which adds another layer of complexity.
Right. Involving the joint makes it trickier.
Definitely. And Chauffeur's fractures, affecting the radial styloid, that little bony prominence on the thumb side, often from an axial compression force.
And what about in children? You mentioned their one peak.
Yes. In children, we frequently see incomplete fractures, like green stick, where the bone bends on one side, breaks on the other, or torus fractures, which are like buckles in the bone cortex.
Like a dent.
Sort of, yes.
Yeah.
And critically, growth plate injuries, known as Salter-Harris fractures, are also common in the younger population. These require very careful management to avoid any long-term growth disturbances.
That variation in fracture patterns is remarkable. It must make diagnosis incredibly critical. So once a patient presents, with that immediate pain, swelling, maybe even a visible deformity, what's the very first priority for clinicians assessing these?
The initial assessment is absolutely paramount, non-negotiable.
Okay.
Clinicians must meticulously document the exact mechanism of injury, how did it happen, and then perform a detailed physical examination.
What does that involve?
It includes carefully checking the integrity of the skin is it an open fracture, assessing circulation to the hand and fingers, capillary refill, pulses, and critically, evaluating sensation to rule out any nerve involvement.
Nerve damage is a risk then.
Yes, especially of the median nerve, which runs through the carpal tunnel. It can present as acute carpal tunnel-like symptoms, numbness,
Yep.
tingling.
And imaging.
For imaging, X-rays remain the gold standard. Essential views include posterior anterior, lateral, and sometimes oblique projections. These allow us to accurately measure key parameters like radial height, radial inclination, volar tilt. These numbers tell us a lot.
And CT scans.
For more complex cases, yes, or when we're planning surgery, computed tomography, CT scans are invaluable. They provide really detailed 3D views of the fracture pattern and, crucially, any involvement of the joint surface. Seeing that articular step-off or gap is vital.
Okay.
The core decision then really revolves around whether to pursue non-surgical or surgical management.
You've laid out the diagnostic steps really clearly.
Right.
What specifically guides that pivotal decision-making process, opting for non-surgical versus surgical intervention? What are those key parameters you mentioned?
The primary objective, always, is to optimize the patient's long-term functional recovery. It's not just about making the X-ray look perfect on paper.
Function over form, essentially.
In many ways, yes.
Yeah.
Function is key.
Yeah.
So for stable, non-displaced fractures, especially those that are extra-articular, meaning they don't extend into the joint surface, non-surgical treatment is often remarkably effective.
And what does that look like?
Typically, it involves a closed reduction where we realign the bone without making an incision, followed by immobilization. Usually first in a splint to allow for the initial swelling to go down and then into a cast.
Okay. And are there thresholds?
Yes, for adults, acceptable parameters for this non-surgical approach generally include less than 5 millimeters of radial shortening, a change of less than 5 degrees in radial inclination, and less than 5 degrees of dorsal angulation or tilt.
Those are the numbers to watch.
They are. Interestingly, though, for patients aged 65 or older, non-operative treatment can frequently be considered the primary choice for dorsally displaced fractures, even if the deformity looks quite significant radiologically.
Really? Even if it looks quite off?
Yes, unless there's clear neurovascular compromise or perhaps extreme deformity affecting skin integrity. Multiple studies, good quality studies, have actually shown comparable functional outcomes between operative and non-operative approaches in this specific elderly demographic.
That's fascinating. It challenges some older assumptions, doesn't it?
It does. It emphasizes tailoring treatment to the patient's overall health, activity level, and goals, not just the X-ray.
That's a critical distinction, particularly for older patients. But what about those borderline cases or situations where non-surgical approaches just aren't sufficient? When is surgery definitely indicated, and what are the main techniques you use?
Right. Surgical intervention is generally considered when the fracture is inherently unstable, when it's significantly displaced beyond those acceptable parameters we talked about, or if it simply cannot be adequately reduced and held in place non-surgically.
Makes sense.
We have several surgical approaches available. One is closed reduction and percutaneous pinning, or K-wiring. We insert small metal pins through the skin to hold the bone fragments in place while they heal.
Like internal scaffolding?
Sort of, yes. It's minimally invasive.
Okay.
This method is still commonly used, particularly in children and for some simpler adult fractures.
Okay.
However, for adults, especially with more complex fractures, open reduction and internal fixation, or ORIF, is increasingly the standard.
Or at AF. Okay, what does that involve?
This involves making an incision to directly visualize and realign the bone fragments accurately, the open reduction part, and then we stabilize them using plates and screws, the internal fixation part.
Plates and screws. Where do they usually go?
Volar plating, that's when we apply the plate to the volar, or palm side of the wrist, is often preferred nowadays.
Why volar?
It generally offers incredibly robust fixation, which often allows for earlier mobilization and physiotherapy. Though meticulous surgical technique is vital to avoid complications like tendon irritation or even rupture, particularly of the flexor tendons on that side.
Ah, so there are potential downsides.
There are risks with any surgery. For very severe fractures, open fractures, where the bone breaks the skin, or those that are highly comminuted, meaning shattered into multiple pieces, or perhaps in patients who are medically unstable, external fixation might be used.
An external frame.
Exactly. An external frame that holds the bones in position from outside the body. It's often combined with other internal fixation techniques, maybe some pins. It's usually a temporary measure or used for damage control.
Right. And does timing matter? when you decide to operate?
The timing of surgery can be quite important, yes, particularly for intra-articular fractures, those involving the joint, or if there's a redisplacement after an initial reduction. Intervention often needs to happen fairly quickly, ideally within about 72 hours, to achieve the best anatomical restoration and functional results.
Okay, so prompt action is needed in those cases.
It often is.
So we've walked through the diagnosis and the treatment options, both surgical and non-surgical. But what does this all mean for the patient in the long run? What challenges might they face during recovery, and what's the overall prognosis like for regaining full function?
Well, recovery can be quite varied. It really depends on the fracture type, the treatment used, and, importantly, patient-specific factors: age, general health, motivation for rehab.
It's individual.
Very much so. While simpler fractures generally heal well with minimal long-term issues, complex fractures, or those with significant initial displacement, naturally carry a higher risk of complications.
What sort of complications are we talking about?
The overall complication rate following surgical fixation is reported to be around 11.7%,
Yeah.
perhaps a bit higher in some studies.
Okay.
The most frequent neurological complication we see is actually carpal tunnel syndrome. It can affect anywhere from 1% up to perhaps 30% of patients, particularly after high-energy injuries that cause a lot of swelling.
30%, that's quite high.
It can be, yes. Symptoms like numbness or tingling in the fingers can be significant and might even necessitate urgent surgical release of the carpal tunnel itself.
Right. What else?
Other common issues include malreduction, where the bone doesn't heal in quite the right position, or a subsequent loss of reduction after initial treatment. These might require a second procedure to correct the alignment.
More surgery.
Potentially, yes.
Hmm.
Tendon complications can also occur. Things like irritation from plates or screws, or even rupture, especially the extensor pollicis longus, or EPL tendon, which helps extend your thumb. That's a known, albeit uncommon risk, particularly with some older plating techniques or certain fracture patterns.
Hmm.
And a more serious, though thankfully rarer, complication is complex regional pain syndrome, or CRPS.
CRPS.
Yes, it's a debilitating condition characterized by severe, disproportionate localized pain, swelling, stiffness, skin changes. It can greatly hinder rehabilitation and long-term function.
That sounds difficult to manage.
It can be very challenging. But whilst complications are a concern, a key insight from recent research, I think, is that early, often quite aggressive, physiotherapy significantly reduces the incidence of long-term stiffness, even for fractures that seem relatively minor initially. Early movement is key.
That sounds challenging, but that insight about early physiotherapy is absolutely vital then. Just how critical is rehabilitation in not just preventing these issues, but ensuring the best possible recovery for the patient?
Rehabilitation is absolutely paramount. I can't stress that enough. Early mobilization, guided by the surgeon and therapist, is crucial to prevent joint stiffness and promote functional recovery.
When does it typically start?
Physical therapy, or physiotherapy, typically begins within days to weeks after surgery, or as soon as the cast is removed if treated non-operatively, always depending on the fracture stability and the specific treatment.
Okay.
While most patients do regain significant function, you need to understand that full recovery from a distal radius fracture can take up to a year.
A whole year.
Yes, for full strength and endurance to return. And some residual stiffness, or perhaps an ache with certain activities, might persist for 2 years, or even permanently in some cases, particularly after very high-energy injuries or perhaps in older patients with pre-existing conditions like osteoarthritis.
So managing expectations is important.
Hugely important. Patient education about realistic recovery timelines is key. And finally, something we really need to emphasize. For older adults, experiencing a distal radius fracture should always trigger a comprehensive evaluation for underlying osteoporosis.
Back to the bone health point.
Exactly. It's not just a broken wrist in isolation. It's often a vital indicator of systemic bone weakness and a significant predictor of future fragility fractures, potentially much more serious ones like in the hip or spine.
So it's a warning sign.
It's often the first major alarm bell for underlying poor bone health. Addressing that through investigation and potentially treatment for osteoporosis is a crucial part of the overall management, looking beyond just fixing the fracture itself.
This has been incredibly insightful. Thank you. For you, our listener, the key takeaways seem really clear. Precise diagnosis through that thorough clinical exam and appropriate imaging is crucial.
Yes.
Treatment needs to be highly individualized, based on the specific fracture, but also very much on the patient's needs and age.
Absolutely.
And early, tailored rehabilitation is just fundamental for optimizing recovery and function.
Couldn't agree more.
And as we've just heard so clearly, for older patients especially, seeing a distal radius fracture should serve as an important alarm bell for wider bone health, prompting that conversation about osteoporosis investigation and management.
Which really leads us to a broader question, I think, for all of us working in healthcare.
Go on.
How do we continually enhance that interdisciplinary coordination between the emergency department staff, the orthopedic surgeons, the physiotherapists, the GPs, maybe geriatricians? How do we make sure we're working together seamlessly to ensure the best possible outcomes? Not just for the fracture itself, but for the patient's overall long-term well-being and their future bone health.
That's a powerful thought to consider that joined up care approach. If you found this deep dive valuable, please do consider rating and sharing it with a colleague. It genuinely helps us reach more professionals like you. Thank you so much for guiding us through this really essential topic today.